Well, good morning again. Well, I don't know where you are. It may not be morning where you are. It's morning for me. And look forward to being here with you. Couple of announcements maybe I'll make. One, as of yesterday, we have completed the hemoperfusion guidelines, which hopefully will be published soon. So look forward to that. It was a big process. It took us a year and a half or so to get that accomplished. I think it was over a year and a half. But I think they'll be a good asset for people that want to put their toe in the water for hemoperfusion and give them guidelines and some boundaries how to do that. The other note, and I think these IRRR sessions will probably go on through to about November. And I have announced to the Hemodialysis Academy faculty that I'm not gonna participate in the faculty next year. So you'll have a new host hopefully for RRR. The academy is pretty even though there are only two of us today, the academy's pretty committed to continuing the RRR sessions going forward. And oops, I'm just not sure who's going to I just lost my camera. Let me see if I can get it back here. And I lost it because I was fooling with the buttons. So there will be continuation of RRR. Now my camera's off, but I'm not quite sure yet who's going to be hosting it. But that will be a new feature, probably starting in November, whenever the academy ends. I think these sessions are booked out for a while yet, but then they'll turn over to somebody else. I'll still attend, but as much as I can, but I won't be the host of them. It's just difficult to host them when you're not kind of in the trenches and have your own cases to talk about in case there aren't cases for others to talk about. So Erica and Jeff just joined. And so the other announcement I made for you two guys is that the hemoperfusion guidelines have been completed, and hopefully very soon will be published for everybody to provide guidelines and some insights on the best practices recommendations for doing hemoperfusion these days. Jeff or Erica, anything you want to say about that since you were on the study group?
Woohoo.
Oh, that was a mouthful, Jeff.
Woohoo. We're done. That was a year and a half or more. It was a big project.
Nobody's showing their videos today either.
Mine's not working. It's not giving me the option.
Well, we're getting a few more people, some old timers, Dan, and there he is. I'm glad he's showing. Oh, he's working today, a working man.
Cowgill, how's it going?
Good.
How's life in Cali?
You know, we have had an amazingly beautiful summer, and it's going to continue through the weekend. Instead of temperatures in the hundreds, we've had temperatures in the mid 80s to early 90s most of the summer. It's just been glorious.
We're kind of like that around here in Colorado.
Yeah, you're gonna get that big white stuff dumped on you soon, though. What do you got going there today, Dan?
Yeah, we've got this is our friend Snoopy, who presented to us about 2 weeks ago. He originally was up in the mountains on a family trip. The owner reported that he had some acute gastrointestinal signs, some vomiting, diarrhea, and after that trip presented to its primary vet, where it had an acute hepatopathy. within the ALT, and it was predominantly hepatocellular, in ALT around 2000. Alk Phos was in the 3000 range, and a GGT around 45. Was not hyperbilirubinemic at that time, and then developed a progressive AKI. This dog was hospitalized at a nearby specialty hospital where the dog became anuric, was hyperkalemic, and gained about 2 kilos of water weight. So we ended up getting this dog transferred to us. Lepto. So this dog had a lepto booster about a month and a half ago.
Mm.
Lepto.
Not going to confuse things.
Yep. So lepto witness was negative at the time. We did some.
Oh, it was negative. I would have thought that maybe it would be confusingly high.
Yeah. So it's been historically negative here, and even doing a convalescent MAT on the dog, it just looks consistent with vaccination. The titers were around 1 to 200, so just nothing out of the park.
The vaccinal titers can go really high. They can go up into the thousands transiently.
So working diagnosis is that this dog probably got into some sort of hepatotoxin and had a secondary AKI as a result of that. His ALT has come down. He's hanging out around the 350, 400 range. GGT is around 30. Let's see what his blood work looked like today. And his Alk Phos is in the thousands. Alk Phos is 1200 today. So he's converted. He's now polyuric. He still has a grade 5 AKI, and we're treating him every other day. The owner reports he's doing pretty well at home. Clinically much improved from when we first saw him. He's playing with the owner, fetching a ball, doing all that. So they're very happy with his clinical status. We're just kind of in the recovery phase here and kind of prep the owner for hopefully about a 4 to 6 week period of dialysis and see how this dog recovers. But overall,
so what were his numbers when he started? And how high did his weight go?
He had a creatinine of around 12, a potassium of close to 7. His BUN has been kind of in the 50 to 60 range, so definitely in a nitrogen deficit.
Well, he's got liver failure too, so he's
Yeah,
not generating a lot of.
Oh, he also had some glucoseuria initially, so I was curious if this dog could be like a copper dog, and maybe had a copper hepatopathy. So we kind of put that on the owner's radar, and we may consider some liver biopsies in this dog. I'm getting a recheck UA and UPC today, because his initial proteinuria, his UPC was around 12. I was concerned that most of that was going to be tubular, and just want to trend that. We'll end up submitting an SDS page on him today as well, but he's definitely an interesting case. We had a similar case about a year ago. These dogs that come from the mountains, I don't know what they're getting into, if there's some sort of mushroom up there or whatnot that is precipitating more of an acute hepatopathy and then a secondary AKI. But this is pretty similar to a previous case of ours, and hopefully it'll respond as well as that other one did.
Well, that's great. We've often had the debate around our unit. If it were a lepto, what comes first? Does the AKI come first generally, or does the liver impairment come first? So I would take a poll from the group. What's the experience from the group here with your lepto patients? What do the vast majority of them present with the AKI first and then the liver failure shows its face, or do they present the other way with the liver failure first and then the AKI, or do they occur together?
I
Anybody have-
usually get AKI first.
I do think it kind of depends on the Cerevar as well. You know, you definitely I feel like we don't see as many as the liver lepto cases here, but you know, they're, you know, definitely we'll see them from time to time, but it's just, I feel like it's not as common seen in the past.
Yeah, my gut feeling, and we never looked at our cases to kind of get the answer, you know, and so you take gut opinions for what they're worth, or they're usually skewed. But I think that the kidney failure usually shows up first as well. Some occasionally you can document very, very nicely that the liver is first, but I think the majority of them that we see, and we see a variety of different Cerevars, or we used to see them in California, that the AKI is first and then the liver comes. So how high did this dog's bilirubin go?
It's been normal the whole time.
Oh, I thought you said he got hyperbilirubinemia.
No, it's never been hyperbilirubinemia, so it's just all been an acute hepatocellular injury there, and with the AKI, dog's definitely now polyuric and is losing quite a bit of weight as a result. So just keeping up with his hydration has been a bit of a challenge. Probably you know, dual component there with, you know, the liver involvement and some medullary washout, but also, you know, it's recovering from you know, the AKI here. So it's just you know, definitely prep the owner for about a 4 week treatment plan here, and you know, they're very much on board. I still am. The dog's liver values in 2 weeks haven't really completely resolved. So I do think we need to go down that avenue of getting a biopsy of this dog's liver. I just, it might be a scenario where, you know, we do it one of these weeks, you know, keep him in hospital and do like a regional citrate treatment afterwards. And you know, just to get some of those answers for us, probably sooner rather than later. But yeah, I think clinically the dog's doing much better, and you know, it's just really going to be a matter of time and you know, recovery window here of, you know, how long is it going to take for these values to recover.
And where's his creatinine now?
10.3 today.
Oh, so it's how long you've been treating him, Dan?
So this is week 2.
Oh wow, so it's pretty slow to recover.
Yeah. We've had a couple of these kiddos that are, you know, a 4 to 6 week time frame of treating, and so you know, they get these massive injuries, and it's just, you know, the recovery process is just slower than what any of us would like, right?
Well, I think that's a good point to bring up, because you know, in the olden days, when ethylene glycol used to be about 60 or 70% of our caseload, when we first really started doing dialysis, and before they changed the laws in California about additives for antifreeze solutions, antifreeze was our big etiology. And that was a horrible disease, and you know, only 10 or 15% of those patients ever recovered, and there were very, very long, protracted recovery periods. And then, you know, then lepto came along, and Lilly came along, and a few other, and my observations have been is the major etiologies for AKI change about every decade. And about every decade we get a new etiology. Maybe this decade it's NSAIDs, I'm not sure, but we got very used to dialysis patients that get better in 2 weeks. And then, that becomes kind of the norm. And then we forget about the fact that sometimes these animals really get a big hit to their kidneys and they're not going to get better in 2 weeks. It takes them minimally 3 or 4, 5, 6 weeks to get better, and sometimes months. So that's just something to really keep on your radar.
Can I ask a question?
Erica, do you have any money?
No, I'm poor. I work at Penn.
This is a podcast, the ka-ching, ka-ching, ka-ching. We expect some money coming in.
I'm curious, Dan, like how you're going to interpret the UPC when he's on dialysis.
Yeah, good question. I want to just see some trends here. And I think initially when we see the massive hit to the kidneys, we'll get, these high UPCs. You see them in the lepto patients as well, and those should improve over time. I want to see some trends, but I guess the other thing is, did the vaccine, the recent vaccination play a role? And do I worry about some sort of immune complex disease in this dog? And, do we end up biopsying the liver and the kidney as well? I think those are going to be some questions that I want to try to answer initially with the SCS page and looking at his UPC. But I think it's a good question. With dialysis, does that skew some of our data? Probably not, at least initially. And if I see a trend that he's improving, well, okay, I do know that he's got, tubular injury and we are recovering here. So, how much weight do I put on? If we start to see improvement there, I guess for me personally, those are comforting numbers. And, we're just probably going to make our recommendations based off of what that looks like. And, ultimately, if we're still persistently elevated in the 10 to 15 range, it's just, that's concerning to me. And, ultimately, I'm going to biopsy that kidney.
Well, I think Erica's question is a good one. We've actually looked at this a bit. And obviously, the UPC is a ratio to the urinary protein to the urinary creatinine. The urinary protein, that would be a measurement that you likely could follow, just the protein concentration by itself. But when you index it to the urinary creatinine, it takes about 4 or 5 days off dialysis before your creatinine concentration is going to plateau and stabilize. And I would suspect that you're going to have a hard time interpreting those numbers. And again, I think you could look at the urinary protein concentration as a measurement all by itself, but very often, even if we get a UPC on a Monday after the patient's been dialyzed, it could be in the hundreds. So that may be difficult to predict. The other test that you might, and we don't have good data to follow this at the moment, but I would be in the habit in all of these patients to run cystatin Bs. That's an active kidney injury marker, and our experience would be that as the animal's kidney injury starts to recover, that you'll get changes, hopefully improvement changes in the cystatin B. That would maybe be a marker of recovery. There are other biomarkers that I think are better than cystatin B, but unfortunately they're not commercially available. But our experience looking at 2 or 3 other markers, and the best one is serum inosine. That's my favorite. I just can't get IDEX to bring it to market. But serum inosine is linked to cellular ATP or cellular energy metabolism. So it's a downstream metabolite of ATP. So it really gives you some insights about energy metabolism in the tubules. And ordinarily, cystatin inosine is high. It's a blood test. That's why That's why they're not going to market it, because you have to put it in a stabilizing tube. But it'll be high, and then it'll just drop like a rock within an hour or two of the injury. And then as the injury recovers, then the serum inosine concentration starts to come back up again. And it's really predictable, and it's really great. We don't have similar data with cystatin B, but with cholesterol and some of the other markers we've looked at, they were very predictable of recovery and turnaround of the injury. The other marker that we've been using in lepto in particular is C-reactive protein. And for a lot of inflammatory diseases, when the C-reactive protein starts to come back to normal, then that's the point where we're pretty confident that the animal's turned the corner and is about to recover. So those biomarkers may be helpful, but I'm kind of with Erica. I think you'll have a hard time interpreting the UPC.
Yeah, and I definitely put more weight in the SDS page too, because if I get more, tubular markers and tubular protein, then I worry less. But I think that's where just using the test. No, there's no perfect test, right?
Yeah, well, I think that test would be fine, but the UPC is gonna give you data that I'm not sure you can trust.
I agree with you on the protein though, just trending how much protein is being lost. That's typically what I look at as well, because yes, we're dialyzing this patient down, we're clearing creatinine. That's gonna fluctuate depending on like when you grab that sample too, and so yeah, it makes it a little bit. There's some confounding variables there, but I think just globally, just trying to get an idea of what the protein loss is looking like, and then from an SDS page standpoint, am I going to be recommending a biopsy of this kidney depending on what we find there as well?
Yeah, the reason that we index these markers for urinary markers for creatinine is because of the changes in urine concentration that can occur. Well, your dog's going to be isoscenuric, for all of this period of time. So you really probably don't need to have an index marker, because there's not going to be any concentration of the proteins. And so just looking at the raw protein concentrations is probably just as valid as anything. Well, that's a good case. Any other questions or comments? Thanks, Erica, for bringing that up. That's a good point. Quiet group today. Well, we hope that you'll keep us posted on this, Dan, as we go forward, so that because it looks like this is when you're going to be dialyzing for a while.
Wow, yeah. I definitely will. Yeah, I'm curious what we find on the liver too, because that is going to be kind of our next step too.
Anybody have any questions about the prescription or any issues that you've had with the dialysis in this dog? Or have you had any?
Other than the F40 dialyzer, it doesn't exist anymore.
Yeah, that's the good one. We love that dialyzer.
I know.
What are you using, an F3?
We're using this Polyflux 6H dialyzer.
Yeah, that's a pretty good intermediate dialyzer, but I don't think it wasn't as efficient as the F40.
Yeah, it's good enough for this dog. For the massively fluid overloaded patients, when you're trying to pull off more fluid, it's nice to have a nice dialyzer that you can can handle the KUF that you want to deliver.
Our experience with the F40 also was that it wasn't quite, but it was almost as efficient as the F160 in a smaller package. We could get just about the same clearances out of that dialyzer as an F160 at comparable blood flows. Great. Andreas, you had some questions you wanted to bring up? Thanks, Dan.
All right, I gotta go see appointments now. We gotta go work.
whatever that is.
Yeah, thank you. So we were discussing this case that apparently the dog didn't do too well, right? So you were telling me that it was probably a dialysis disequilibrium.
Well, no, you need to describe the case for everybody because I'm the only one that knows what you're talking about.
Yeah. So we had this patient with Ehrlichia. It was diagnosed in another clinic, and it was being treated for probably 2 weeks before it was presented to us. And they never told him anything about the AKI or didn't bother to check how his parameters were. So when we received this patient, he was with a creatinine of 24 and a BUN of 288, if I remember correctly. For a couple of days, we had him on just medical management until the owners decided if they wanted to pursue dialysis. And in this couple of days, he was polyuric, but he eventually became anuric. And finally, the owners decided that they wanted to pursue dialysis. So we managed to get him in the IHD platform. And the first session, I believe I aim for a 8 hours treatment with a 5% IRRR.
Per hour.
And just let me check if I have the values here. But well, anyway, the first session went smoothly. He was feeling better. His potassium was normal in the first couple of days, but as he became anuric, he eventually became hyperkalemic. Not too hyperkalemic, probably 6.5 or 7 was his highest point before the first treatment. So the first treatment, we managed to bring him back down to a BUN of 164, if I remember correctly. But I was just asking Dr. Cowgill that in the second treatment, everything went fine. In the beginning of the treatment, no signs of disequilibrium, no anything. His blood pressure was stable. His consciousness was stable. And in this treatment, I believe I aim for a 8-hour treatment with a 10% URR. And everything went smoothly. The thing that we were talking about is that apparently maybe the BUN wasn't exactly a good measure in this time because we finished last treatment with 160 something. And in this second treatment, we started with a 154 BUN. So it didn't make much sense if he was anuric and he was producing any urine, right? So when we disconnected him from the dialysis machine, he couldn't stand up and he was probably like 15 minutes later or 20 minutes later, he died and didn't present any signs. So we did gave him a dose of mannitol in the middle of the treatment, and in the first treatment also. So I was wondering if it was because of dialysis disequilibrium or what could I have done different this time.
Yeah, so Andres presented that to me as an email and I was, that's really not, you can see this delayed dialysis disequilibrium syndrome. I think we don't see that as commonly, but it can occur 12 hours or so after the end of the treatment. it may be that if that's what was going on in this patient, that it was actually sort of ongoing right at the end of the treatment. But you did a much more aggressive treatment on the second treatment. I think you were targeting 10 mils per urea reduction of 10% per hour.
Yeah.
Over 8 hours. That you know, for if the BUN was really 154 on the second treatment, that I think that's something that you would probably be able to get away with. I mean, I think those numbers would be you know, consistent with guidelines and would be fine. But my curiosity was that the animal's BUN went from 164 post-treatment to 150 something pre-treatment on the second treatment. And that next treatment, I presume, was probably within 12 or 18 hours of the first one. And
No, it was probably like we finished the first treatment at 11 p.m.
Mhm.
and we started the second treatment at 7 a.m. So it was really not that a lot of time after.
So two things you would have expected. One is that there would have been some rebound after that treatment. So it's just curious, particularly when the animal's clinical function hadn't improved. And I'd be curious, I don't remember the creatinine changes during the
Um, I believe he ended up with no. Let me look that up for you.
So my concern at first when I responded to Andreas was that the BUN number seemed kind of funny. It was low. I would have expected it to at least jumped up 30 or 40 points. And so you may have gotten a kind of a false sense of security that the BUN was low. In fact, it could have been close to you know, close to 200 again, which, you know, 200 you could probably still treat an animal at 10% per hour for over a long course of treatment, but that animal would still be at some risk of disequilibrium, and it could have jumped even higher than 200. And so I thought maybe that pre-dialysis number was incorrect. This could be disequilibrium syndrome. I mean, in a dog, they're not as profound as a cat usually is. The sign just being weak is not kind of the first signs that they show. They usually show some angst or anxiety or agitation first, and they usually start to vocalize a bit. But if the animal were sedated or for any other reasons, you might not have seen those signs, or it could have been into something entirely else, different. You know, maybe some kind of heart failure or bleeding, those sorts of things. So I didn't have a good answer for why this animal died so shortly after the treatment. But one of the issues that I was curious about was why was the initial pre-dialysis BUN lower than the post value, and at a, you know, something closer to 200, the animal may have been at that intensity of a treatment. The animal may have been at some risk for disequilibrium.
Well, now that you mentioned, maybe he was a little bit restless in the middle of the in the end of the treatment, but I assume he was just he just wanted to move a little bit because of the long hours he was laid down, but nothing too critical, right? No vocalizing like too much different than he was his usual self. And also I want to point that I have some other BNs that wouldn't support a lot that he was with he had a BN of 200, because I usually try, because I'm starting with my dialysis unit, so I usually try to take a lot of BNs. So let's say he started with 152. I also noticed that when you do this, the dilutions in the catalysts with IDEX, you sometimes don't get the exact number, right? But
Right.
so he had 152. The next one was 113. Let me just tell you exactly the hour of this. So 152 at 7:24 a.m. That was his starting BUN.
Mhm.
And the second one at 9:20 a.m. it was 113. And even the third one, it was 87 at 11 a.m.
So you had been on target for an 80% reduction or more, perhaps more.
Sorry, I don't do the calculation myself, but I'm the guy right now.
Yeah. Well, I mean, you were doing 10% per hour for 8 hours. That'd be a big reduction. So I don't know. Maybe we'll open it up, see if anybody else has other ideas of what might have happened in this dog, or if you've had similar experiences. I think disequilibrium would be on the table. That may not be the highest reason for the manifestations in this dog, but it'd certainly be something that you would consider. And
Well,
your BUN trends would maybe suggest that your 159 value was correct. It's just funny that that number's not higher. Anybody else have suggestions or insights?
well, I do believe it had to do something.
Well, and maybe what this tells you, and because disequilibrium will sneak up on you, and I probably see it more than anybody because I'm usually overly aggressive, and my technicians have to say, "Cowgill, you sure you want to do that?" And then I'll get a little bit of religion and say, "Yeah, you're probably right. We should slow down a little bit." And it's when it really gets you when you're trying to be, a little over efficient. And then it sneaks up on you. And again, typically in a dog, they'll give you some warning. Unfortunately, in cats, you usually don't get any warning. They just kind of drop dead. But dogs, losing my voice here, dogs almost always give you some warning during the treatment because I think they get a huge headache. And so they get kind of restless, and they get kind of glassy eyed and kind of starey, and then they'll usually start vocalizing, whoa, rah, rah. A lot of the signs are almost exactly like, boy, I really got to have diarrhea right now on the table, so do something about this. And it's hard to separate those behaviors from the disequilibrium. And so when you see those signs, you can't just presume the dog's going to have diarrhea, that maybe it is disequilibrium and act. But so I think that it makes sense that that's what it could be. It's just you wouldn't have predicted it, and that's often when you see disequilibrium, is when you don't predict it, or when you're kind of complacent about it. It sounds like you were being very proactive, but and again, sometimes we'll give the mannitol. You may even give a couple of doses of mannitol during the treatment. Usually we don't give it until at least after a couple of hours. That's when the signs usually start to occur, is after a couple hours of treatment. And then if we have a patient like this that we're really concerned about it, then we'd commonly give a dose of mannitol at the end of the treatment. Because if you gave it in the middle, by the time you're at the end of the treatment, you've dialyzed most of the mannitol out. And so you might give a second dose as you're closing up the catheter. that would be just another suggestion. And that's a good time to give it, because then you can give it, through a central vein, and you don't have to dilute it, and you don't give the patient quite as big a volume load if you're giving it
Sure.
centrally.
Yeah, maybe next time I'll do that.
Well,
Give it in the middle of the treatment and in the end of the treatment.
yeah, and again, you don't really get religion about disequilibrium syndrome until you've created one, and then after that, it's just there are two things that I find that people need to have a problem happen before they get really fanatic about it. One is not securing your bloodlines to your harness or whatever, and so that's rule number 2 in our unit. Rule number 1 is asepsis, asepsis, asepsis. Rule number 2 is thou shalt always attach the harness or the bloodlines to the harness. And they don't really have a lot of interest in that until the animal, their first patient jumps off the table and pulls their catheter out. A catheter that you've spent hours maybe getting in, and the patient that needs a dialysis, now you got blood all over the room. And after that first episode, then they get religion about rule number 2.
Yeah, you're right.
So I would say, I think it's reasonable that you could consider that this was a disequilibrium syndrome complication. I'd probably put that in the notes, because at the moment I don't know, unless there's some other systemic comorbidity in the dog, heart issue or something like that. And I
No,
don't.
we did check his heart. I actually think you're right, because everything else was doing kind of great. His anemia wasn't that badly because of the leakia. He had blood transfusion before. Well, his potassium was high, but really not that high. Probably
At the end of the treatment,
7.
it would have been high. It wouldn't have been high either at the end of the treatment.
Yeah. Mm-hmm.
Yeah,
I think you're right. Looking at it into perspective, I think it was the disequilibrium, because he was a little bit restless, but maybe I didn't realize.
that's an aggressive treatment for the second treatment. I think on a third treatment, that would have been fine. And their sensitivity to disequilibrium becomes less with each treatment. And usually by the third treatment, these patients, you can just dialyze them anywhere you want. But the first and second treatments are a little bit critical. And starting with a BUN of 300, that's a high number. So there might have been things going on in the brain already, a bunch of idiogenic osmoles or something in the brain as a result of that really high BUN. And then he got 2 treatments really kind of in pretty rapid sequence. Since you ended at 11 o'clock and then you started the dog up again the next morning, that's pretty rapid sequence. So I think that maybe is the best explanation, but it remains a little bit atypical, I think.
Yeah, maybe if I'm going to do that the next time, I should probably stick to the first treatment guidelines or something, right?
Yeah.
Yeah, okay. Great, thank you.
You're welcome. Anybody else have thoughts or considerations? A disequilibrium syndrome ruins your whole day, particularly if they die. Dogs, usually, you give them a big slug of mannitol, and I would ask what dose of mannitol you use.
Le haga la hoja de citología.
I've gone now to giving a gram per kilo. I used to just give a half a gram per kilo, and then I went up to 0.75. But if I'm really concerned about disequilibrium, I'll give them a gram per kilo.
Yeah, that makes sense.
And then the other issue you can do is you could sodium model them. I think, we've had pretty good luck with sodium modeling, and again, maybe that we just have enough sensitivities to disequilibrium that we don't see it. But if we have an at-risk patient like this, particularly if the sodium is low at the beginning, we'll go ahead and sodium model them throughout the treatment. It's something that's pretty innocuous to do on the first or second treatment. Depending on your machine, you may be able to do it automatically and not have to do it manually. But that seems to provide a bit of a buffer as well.
Sure. Yeah. I really don't have a lot of experience with sodium modeling because I haven't got to that part of my journey, but I'll try to do it next time.
Yeah, so, and I don't know what the starting sodium, let's say the starting sodium was 142 or 43, something like that. We would model a dog up to 155, 160
Yeah.
over the course of the treatment. And that adds a lot of solute to the extracellular fluid, and it's a buffer in addition to the mannitol.
Okay. Yeah.
We'd probably do that on a first treatment. If the sodium's not already too high, we'd probably, on a dog that comes in with or particularly a cat or a dog that comes in with a 300 VUN, I probably would sodium model just as another mediating another risk.
Sure. Yeah, I usually get patients with 300 BUN. I really don't get too much better patients. and letting this aside, I had the other question. I'm not sure if anyone else had other topic. If not, I want to ask about the SPAT treatment.
Well, we have a few minutes. You want to talk about that question?
If nobody else wants to ask something,
I hear
no?
silence.
I guess not. So my other question in the email was about the single dialysis, no, the single pass albumin dialysis. So I had this patient with IMHA. We didn't have a plasma available, and he was just hemolyzing all his transfusions. So some doctors from the human side just recommended if we could do this kind of treatment, and I was asking if it will be of any benefit with a IMHA or if you had any experience with it. So maybe we can start with that.
Albumin dialysis is a technique. It's an old technique. I don't think it's used very often. It has been reported in veterinary medicine. I think it was Karsten Bant from Florida. I know he presented it at an ACVM meeting one time, but it was primarily to get rid of protein bound toxins. I mean, that was one of the major indications for it. And so you put albumin in the dialysate, which is an expensive proposition by itself, but you recirculate the dialysate. So you have a reservoir of dialysate that has albumin in it. And the theory was that you would take during your dialysis session, then the toxin could be deliganded from the blood proteins, come across the membrane and get trapped on albumin that's in the dialysate. So it was a way of really trying to get rid of high protein bound solutes. I don't remember exactly what all the other indications were, but I think and I forget what indication he was. I don't know if it was a hypercholesterolemia. There was some disease that that he had reported this and had done the albumin dialysis in order to do that. But that therapy isn't going to remove antibodies. The antibodies aren't going to get across the membrane. So it's mostly a way of trapping solutes. And they could be solutes that are just like we see with a lot of intoxications now, is that you fill up all of the intravascular binding sites, and then you may have free toxin floating around in the system. And you could trap those toxins across the membrane by having albumin in the dialysate, so that if they got across the membrane, they would get trapped, or even deligand them from the proteins in the circulation and reattach them to the proteins in the dialysate. But I don't understand how your human counterparts that you were talking to, how that therapy would have been a benefit for an animal with IMHA, where it's the antibodies that you really have to get rid of. The only treatments that are going to do that would be plasma exchange.
Yeah, I thought about the same thing, because I read a little bit about it, and it's mostly used instead of the MAR system for liver failure and
right, for trapping
other toxins.
bilirubin and some other hepatotoxins.
Yeah, exactly.
I think that was the indication that Dr. Karsten had reported, is he was treating hyperbilirubinemia, I think.
Sure, yeah.
It would be a more efficient way than treating it with dialysis. With dialysis, we get a little bit of absorption onto the membrane, as you've all recognized. When you treat an ICRRR patient, your dialyzer comes out yellow at the end, and you would some of the unconjugated bilirubin might come across, or the conjugated bilirubin, one of those two, the one that's water soluble, might come across. But otherwise, dialysis doesn't change the bilirubin concentration very much. But the MAR system, by having this albumin on the other side of the membrane, you could trap that bilirubin as it came across the membrane on the albumin that was in the dialysate.
Yeah, it probably will help with an ICRR's patient if it was hyperbilirubinemia from the IMHA, but it will do nothing with the antibodies.
Oh, was that the reason that they were recommending it? Was because of the hyperbilirubinemia?
Not really. It was just a short conversation, because we were both busy, but maybe that was one of the
that was probably the recommendation. Actually, the most efficient way to remove bilirubin is with absorption. And so, if you had some carbon, or you had the vet rescue column, hemoperfusion or hemoabsorption would be that really that can really remove a lot of bilirubin.
And cytosorb, will that help in any way?
I didn't understand you. Say it again.
The cytosorb, will that help in any way?
The type of filter?
No, cytosorb. Cytosorb.
Oh yeah. That device is pretty effective at removing bilirubin. Yeah.
Yeah.
Any of the devices that we currently have in veterinary medicine, which would be the macroporous polymer based absorbers, or the activated carbon absorber, would remove bilirubin.
And how would you feel of using human albumin in this kind of spot treatment? Because then it wouldn't have any contact with the patient's blood, right?
For the albumin dialysis.
Yeah. For the albumin.
Yeah, I think that you could use it for that reason. But how high was the animal's bilirubin?
Well, actually, he only developed icterus like a couple of days because it was after a transfusion. After that, he wasn't really hyperbilirubinemia. Let
You know,
me.
if the bilirubin's less than about 40, I probably wouldn't. I think you get away with that. I used to wait and not really get worried about the bilirubin until it got to 60 or higher.
But
I
but
mean,
let's say we are going to dialyze a patient with other toxins, right? Let's move a little bit from the IMHA because there is not going to do really anything good. But let's say NSAIDs or something else.
well, I'm going to show you. We got a couple of minutes here. Let me just show you, and if I can get this presentation up real quickly, and I'll show you. And I might have missed what you're. I think I showed this at the last RRR. Well, let me try it again. One more. Let me just. Oh, I gotta.
Solo que los datos de que.
Pardon me.
No, nothing.
I'll show you. So the bilirubin, you know, if the bilirubin is not too high, and maybe I think that as we get more and more looking at bilirubin, we might start treating it at earlier stages of disease. But you know, if it's only 20 or so, only 20, it might not be. Oh, this is the wrong slide. Let me go look at a different one here. But if the animal's symptomatic, oh, here's the one I want to show. The animal's symptomatic for the bilirubin, then I think it's worth treating. And then you had two questions, and I think this slide will answer your questions once I get it up here. And then once I tell the machine to share. Share this one. Okay. So this is my screen sharing now.
Oh yeah.
So this
this
is an IMHD. This is an IMHA patient that we were doing plasma exchange on, and this dog has a bilirubin of 60 and was symptomatic for the bilirubin of 60. I mean, it was very neurologic. And ordinarily, this is a 1.5 plasma volume plasma exchange treatment where you would expect a reduction ratio of probably 75–80%. But at the end of the TPE session, the reduction ratio was only 40%. And that's probably for a couple of reasons. One is the bilirubin's distributed, you know, throughout everything. And as soon as we're removing it with the plasma exchange, the intravascular compartment is refilling from the extravascular spaces where the bilirubin is also 60. So you're getting ongoing addition of bilirubin to the patient as you're taking it out. And there may have been some bilirubin generation as well. And so what we did to get the bilirubin down is that we then continue the treatment with some activated carbon plasma absorption, and then did another 3 or 4 plasma volumes of treatment. I guess 3 plasma volumes of treatment, and we're able to reduce it another. This sample here this is where we projected it would be. This sample got lost in the freezer. But you know, we got a 78% reduction with 60% of that, almost 70% of that occurring with the carbon. So that just shows you that you know, hemoperfusion is probably the most effective way of trying to get rid of bilirubin, and it's probably worth getting rid of when you've got numbers this high. If you had numbers down in this range, 25 or 30, I'm not sure I'd go to the bother of doing that. But once they get above 40, I think then these animals start becoming symptomatic for that. And they may be symptomatic at lower values that we or I just don't recognize. And then the other question you had, you know, what was about the rebound. And so here we got the bilirubin down to about 10. And by the next morning, it's already back up to 40. So there's always rebound of a lot of these solutes, and that's why you almost have to do a second or third treatment when you're doing that.
And in this case, why did you choose to do the 3 plasma volumes? Because if it's just because of the bilirubin, it wouldn't be
just because of the bilirubin. So we did this treatment, the TPE, to get rid of the antibodies. But then we added the carbon and did plasma absorption. So the animal's own plasma became the replacement solution. So it was, the plasma was purified in the carbon, at least the bilirubin was removed, and maybe some other uremia toxins, and well, it wouldn't be uremia toxins, some other IMA, some inflammatory proteins maybe also got removed here. Because the carbon will remove those inflammatory cytokines. But essentially what happened with this is we got the benefits of about an 80% reduction in what otherwise would have taken probably 2 or 3 or 4 treatments to get to this point.
And did you give him another 1.5 volumes of new plasma, or just the?
He used his own plasma, so that, you know.
Oh, okay, yeah.
So here's the. Let me share this. Let me go up one.
Yeah, because then it wouldn't make much sense.
So what we do the plasma exchange first, and then we stop the plasma exchange, and then the plasma comes off, and then the plasma goes through the absorptive device and becomes the replacement solution for the patient. So you don't need any more plasma or any more donor replacement solutions. The animal's own plasma becomes the replacement solution once it's purified by the treatment.
And can you do this in the Prismaflex or the Prismax?
Yeah, you can use it. So I showed this last week. Here I'll
this
show
last
it.
week.
Or 2 weeks ago. Here it is here it is on the Prismaflex, but you have to do some manipulations to the Prismaflex to get it to work. But otherwise it works. Here's the best example.
I don't think it's showing your slide on the Prismaflex.
Yeah, okay, hang on a second. Let me get up here. Oh, I'm on the wrong one. So here's oops. Yeah, here. So here you can see the plasmas coming out, going through an absorptive column, green coming in, clear coming out. So you've cleared all the green out of that. And then the animal's own green plasma then, that after it gets purified, becomes the replacement solution. But on the Prismax and the Prismaflex, you have to do some manipulations to the tubing set in order to get the scales to work. And I can tell you about that. I can tell you about that at another time, since we're at the hour already.
Yeah. Okay, great, thank you.
You're welcome. So, well, that was a pretty nice session. Thanks for those that are still remaining. Jethro, you come in and out.
Yeah, it was a good one.
Jethro, any last words? You want to close the session? Oh, he's not paying any attention. He
Thanks.
never pays any attention to me.
That was great.
Okay. See everybody in a couple of weeks then.
Hey, bye. Thank you.
Bye.